Would you guys want to try maybe sharing your screen just to, I don't know, Chris has got us all worried now that it won't work while you're recording. So,
All right, let me
maybe,
try first.
yeah, try. Yeah, looks
All right.
good.
Okay.
Maybe Ravi, do you want to just try to share yours just in case?
Yeah. What's that?
All set. Okay, good evening, everybody. Thank you so much for joining us in your evening, I guess if you're on the East Coast, and in the afternoon if you're on the West Coast. Very excited as part of the Midwestern Vascular Surgery Society New Horizon webinar series. We are going to today, in combination or in sponsored by Shockwave IBL, and we thank them for their sponsorship to discuss challenging BTK anatomy in patients with chronic limb-threatening ischemia, the case for IVL first therapy. We have a fabulous panel here today joining us, and I will introduce them. Actually, I'll introduce them up front here, I'll let them go ahead with their presentations. First, we have Dr. Ambani from Cleveland Clinic. He's the Associate Program Director of the Vascular Surgery Fellowship at Cleveland Clinic, and his clinical interests include complex PAD, carotid, and aortic work. He enjoys traveling, watching sports, and attending F1 races in his free time. I guess Robbie, I'll let you go first and I'll introduce the other speakers as they come along, if that's okay with you.
Sounds great to me.
All right, fabulous. We see your presenter view, Robbie.
Oh,
Perfect. Yep, there it is.
you guys good?
Yep.
All right. So good evening, everyone. Thanks for logging in and joining us for this webinar. Um, as Nick said, my name is Ravi Ambani. I'm one of the faculty at the Cleveland Clinic. Tonight, we're going to be discussing all aspects of lithotripsy and its use for our challenging CLTI patient. And I want to start off tonight by discussing the types of lesions that this technology is good at treating, how calcium modulation does work, and what evidence we have in support of the use of intravascular lithotripsy. Here are my disclosures. So, as we all know, atherosclerotic occlusive disease occurs when consistent plaque deposition leads to a stenosis of arterial vessels. The calcium within these plaques is very complex. It's layered and involves both intimal and medial disease, and this can present a treatment challenge when trying to treat a stenosis. While this process can affect many arterial beds that's in the periphery and the cerebrovascular system and the heart, the prevalence of peripheral arterial disease in the United States alone affects nearly 8.5 million people annually, with over 850,000 procedures being performed annually. And the significant amount, 40 to 70% of these patients have complex calcified lesions. So when we expand our thinking of peripheral arterial disease and start focusing on the care of the CLTI patient, then this challenge that we have as clinicians becomes even greater, wherein the failure to effectively treat our patients now becomes associated with higher rates of death, amputation, myocardial infarction, and stroke. The majority of our CLTI patients
Hey,
will have.
Robbie, I'm sorry. Your next slide hasn't really come across completely. I'm sorry to interrupt you. There.
Oh, there you go. Sorry. As I was saying, when we're dealing with CLTI patients now, we're dealing with higher rates of death, amputation, MI, and stroke when we're not treating them. These patients have multi-level disease. They have a high proportion having infrapopliteal lesions. And to restore inline flow to these patients, we're now facing longer treatment lesions, higher incidence of chronic total occlusions, smaller blood vessels to treat, and heavier calcific burdens. So why does the amount of calcium matter? I think the most simplistic way to answer this question is to think about the possible complications from treating. So higher calcium burdens can lead to vessel dissections, perforations, and embolizations. They can also lead to a failure of stents, with these stents being crushed by the external calcium. They can make delivering large bore devices challenging, with our sheets and our devices unable to track. And with a heavy calcific burden, you can increase the amount of vessel recoil. So all these issues lead to the same clinical outcome: a patient with CLTI and an unsuccessful treatment algorithm. So with the use of intravascular lithotripsy, we now have a way of modulating calcium to reduce elastic recoil. We can treat lesions in challenging anatomic locations. We can safely treat a stenosis with minimal risk of embolization and dissection. And now we have a way to effectively treat our CLTI patient and help them heal and move forward. So we're not just here to take my word for it, but I think we should let's look at the data that we have available for this technology and discuss a little further. Through several clinical trials, we have data from over 1,700 patients. And for tonight's talk, we're going to focus on the Disrupt BTK2 data. And we're going to look into that a little further and talk about it more. So Disrupt BTK2 was a prospective, multi-center, single-arm trial that was aimed at evaluating real-world outcomes in patients with CLTI. So this takes out that bias you have from some trials where everything is so rigid and stuck that you can't really apply this. This is real-world patients, 250 of them, over 38 global sites that are going to be followed for a 2-year period. 80% of these patients had a Rutherford classification of 4 or 5, which put them into that CLTI Rutherford classification. Only 20% of the patients enrolled were Rutherford 3 or claudication. So the primary safety endpoint was major adverse limb events at 30 days, with a effectiveness endpoint of a primary procedural success, which is defined as less than 50% residual stenosis for all treated target lesions. So we now have data out to a year, and this shows that freedom from major target limb amputation was achieved in 95% of patients, with no major amputations in the non-CLTI patients. Freedom from clinically driven target lesion revascularization was 85%, and primary patency was achieved in 67% of these patients. So the proportion of patients with a CLTI decreased from 80% in that initial cohort to now 25%. And what's more impressive is the vascular quality of life scores increased significantly on an average of 5-point increase on the scale, which is a significant improvement in these patients. And as we know, the CLTI patients without intervention have fairly poor quality of life. And that's not only from the risk of amputation. So when we look at our trial data, we have the initial studies that are randomized that show good safety, good efficacy, very minimal risk of bailout stenting, very minimal risk of vessel perforation and embolization. Now we get a look at 1-year data, and in a little bit we'll have 2-year data, outcome of real-world patients with CLTI. So we see that in the initial cohort, 80% Rutherford 4 and 5. Now, 59% of these patients have wounds at baseline, and 85% of them have moderate to severe calcium at baseline. Then at 1 year, 61%. So the majority of these patients had healing of their wounds and a significant improvement. Now you've downstaged these patients from Rutherford 4 to 5 to Rutherford 3 or less. And 50% of the patients have no symptoms now. So they're now asymptomatic. So these are people that we were worried about losing extremities and honestly high mortality risk at a year. And now we've changed their whole clinical scenario. The freedom from major target limb amputation for everyone was 95%. And if you look at just the CLTI patients, so 200 of the 250, you have a 93.3%. And this shows that just IVL in general is safe. It's a frontline therapy for calcium modification. It's safe in the below the knee lesions, delivering great outcomes that really redefine how we look at CLTI treatment and what we have to offer for our CLTI patients. So I'll kind of leave with this, and that in general, in patients with PAD and CLTI, these are complicated patients. They have multiple comorbidities, right? Diabetes, end-stage renal, even CKD, prior coronary history. And treatment of these patients can be challenging, especially when you deal with this heavy atherosclerotic burden that plain old balloon angioplasty or other devices may not penetrate. IVL treatment allows for you to effectively modulate calcium in multiple arterial beds, allowing you to deliver whatever your definitive therapy is afterwards with an increased success rate. The available data we have right now from the original trials, as well as new real-world data, show favorable safety and procedural outcomes with IVL. And for me, in my practice, I think with below the knee patients, anything I'm treating, I'm almost always treating with IVL, using IVIS before to really size appropriately, and then doing IVL afterwards for standalone treatment. So with that, I just want to thank you to the other panelists, to Dr. Muad and the Midwest Vascular Society for allowing me to speak today. And I look forward to any questions that you all might have.
Ravi, thank you so much. I'm going to actually leave the questions till the end, if that's okay. And I understand that you're on call as well. So if you have some clinical duties, we also understand that. Okay. So thank you so very much
Of course,
for
thank
that.
you.
Next, we're going to move ahead with Dr. Caitlin Roundtree, extending IVL into BTK, practical use of E8 and complex CLTI interventions. Just as a matter of introduction, Dr. Roundtree is a rural vascular surgeon and director of the vascular imaging at St. Francis Medical Center in Cape Girardeau, Missouri. She's also assistant professor of clinical vascular surgery for the University of Missouri School of Medicine. She has earned her osteopathic medical degree from AT at Still University in Kirksville, Missouri, and served her surgical residency at Henry Ford McComb Hospital in Detroit. She then completed her vascular surgery fellowship at the University of Missouri in 2022, and since returning back to Missouri in 2025, she is focused on improving patient access to vascular care, focused on preventative strategies and education, as well as enhanced efforts for limb salvage and multidisciplinary engagement for improved patient outcomes. So, with that, Caitlin, we'll let you have the floor. Thank you so much for being with us.
Thank you again for the invitation to be able to present this evening. And thank you everyone to signing in. I'm going to get back to the front of this. So thank you for that warm introduction. And I am going to be pulling more from kind of an N of one, if you will, here, looking at some practical use, some of my preferred aspects and utilization techniques for the E8s. So extending IVL into below the knee, practical use of E8 and complex CLTI interventions. I do have a consulting agreement with Shockwave Medical and do presentations for them. Broad applications of Shockwave, again, reiterating and speaking off my colleagues' coattails, the safety has been documented. There's good looking studies, especially large bore access. There's a increasing host in the portfolio provided by Shockwave as far as devices, coronary applications, renal, iliac, actually even common femoral in certain patients, FemPop above the knee, below the knee, just about anywhere you can think of with calcium, you're going to be having some good modulation effect, either as standalone therapy or vessel prep therapy. treating eccentric and concentric calcium. And then again, you can see the coronary C2s, the L6s, the M5 pluses, and the E8s. I'm also put in the javelin down there, which is quickly turning into another beloved technique over in rural Missouri here, down near the boot heel for our patient population. So focusing in specifically more on that E8 portion of the profile, there are 8 emitters across an 80 millimeter long balloon. You're getting 400 total pulses and 10 cycles of 40 pulses, which you can interrupt to be able to split them a little bit further. The really nice piece about this is that you can treat over 30 centimeters of vessel with one balloon. Clinically, the pushability is actually quite nice. It's not going to cross every single thing, which is again why there's always innovation, but it does have a fantastic crossing profile. So 150 centimeter shaft length is one of, I feel, the strong points of the device itself. I do a fair amount of femoral access. There are a lot of patients in our patient population down here in the boot heel, just probably like your patient populations as well across the Midwestern Vascular Society's area of reach and influence, who have had multiple interventions. Potentially their groins are not going to be your access site. You're not going to be able to get good entry through there, whether it's existing bypasses or just up and over on existing EVARs or repeated accesses. I found with that 150 shaft length that coming in either radial, especially with the 5 and 6 compatible sheath, or from the brachial access is going to be able to get you a minimum of the distal SFA, if not to behind the popliteal for above knee disease. So in looking at just that low pressure treatment, reinforcing one of the aspects of the safety of the balloon is that you're getting, excuse the expression, more bang for your buck. You're not treating below the knee tibial vessels with their higher risk of dissection, higher complication rates there, more limb loss with stent placement, and shorter patency on them given the size. You're still using that nice low atmospheric pressure to avoid having to use increased risk of dissection with other balloons or devices. So optimal sizing, this can never be overstated enough, and I am going to make sure I include it. If you've ever heard anything from Shockwave, you've heard about don't undersize. You want to be a 1.1 to 1 oversizing or 10% effectively above the actual size of the vessel. I know Robbie touched on it a little bit there. One of the ways that we know that we're generally undersizing our tibial vessels is the use of IVUS, especially in the drug-coated balloon trials, saying that we're effectively undersizing by about 0.2 millimeters on each vessel. It's a little nerve-wracking to break out a slightly larger balloon than you think you need in the tibials, but you will get better wall apposition, which means better fracturing and better long-term outcomes. Again, it's extremely common to undersize. And again, we're seeing with that undersizing greater risk for needing to utilize a stent for an incomplete treatment. I think I put too many slides about oversizing and undersizing. So some of the features on the E8 portion of the profile of the portfolio, excuse me, that delivery length, what that's allowing for is access beyond the femoral. Coming in from a brachial, it's not everybody's favorite, but in certain patients where the femoral is not going to give you a safe access point or even potentially access to where you need to be, the 150 length does get you down on the average height patient, at least into the behind and below knee popliteal artery. The smaller sheath size is going to limit your hematoma and your access site complications by keeping your size sheath smaller, also less stents. You're not going to necessarily have to upsize your access sheath in. So we're keeping the profile small. The balloon length of 80 millimeters allows for over 30 centimeters of treatment length, so that you're using effectively less balloons. I have found that the rewrap on this, unless you've really worked and pushed its pushability to the extreme needed across a particular lesion, you can utilize this, say, down the tibial perineal trunk, back it up, cross your wire into the anterior tibial, and then continue to utilize it. It does reroute quite nicely as far as being able to utilize it over different areas in the vessels. Pulses delivered is 40 pulses over 10 cycles with a 2 hertz pulsing speed. It is in the faster side. They've really done away with all of the very slow kind of trotting effectively sound the impulses. It's a over-the-wire balloon, so it's not a rapid exchange. So you are preserving that catheter placement if that's a potential fear in the tibials. And it does help improve the pushability somewhat, especially for the particular mounting device that they're on. We're going to take a look at a couple of case considerations. I do find it pretty hard on our technology in our current cath labs to get a nice, clear, crispy picture on the tibial, so bear with some of the results here, but we'll walk right through. So case consideration 1, everyone has seen this. It's an 80-year-old man with a history of a left below knee amputation from a non-healing diabetic foot wounds. That happened back in March of 25, and he'd gone through angiography. There was 2-vessel runoff coming down to about the level of the ankle, not much blush in the foot. He developed wounds on that side, ultimately ending in below knee amputation. He presented back now with another wound on the right-hand side this time, not healing despite wound care. March of 26, he had an angiogram by another provider, said, hey, you've got 2-vessel runoff down to the level of the ankle. Not really too much to do about that, really not much blush in the foot, no good pedal vasculature, but you've got 2-vessel runoff. You should be fine. Fast forward up to April. Now he's had a hallux amputation. He's got the resection of the first metatarsal joint for osteomyelitis. And then we're looking at May. He's actually healing up quite nicely. So let's see, where'd that go? Here we are. So his initial angiogram, you can see the popliteal coming down behind the knee. He has some areas of stenosis into the tibial-peroneal trunk. The anterior tibial really out of the game early after the first few centimeters. And I'm going to turn your attention to that center shot there. It does look like he's got 2-vessel runoff. You look over towards the foot, not really much blush. He's got a little bit of that posterior tibial coming around, trying for the plantar artery. So with him, performed left common femoral access, kept it to a 6 French sheath. And I do recommend working below the knee, giving yourself a nice long sheath to be able to maintain that pushability, have a good working platform. I'm a big fan of actually parking a 90 centimeter and leaving that in the popliteal artery so that you can still inject around. And even if you're using smaller balloons, you maintain that ability to get a good angiogram while you're working if you need it. 014 Glide Advantage wire happens to be my favorite for crossing and for working, especially given that nice soft tip down at the tibials. Here we utilized a 2.5 by 80 millimeter balloon for primary therapy in the peroneal and the proximal mid of the posterior tibial arteries. I did actually on him utilize a javelin, the distal PT, because I could not get that E8 to cross. So you'll learn more about that in just a little bit here. Through that same 6 French sheath, I was able to use a 5 by 80 centimeter to the popliteal lesions. Admittedly undersized, but with the way his groin access was, I wanted to keep that access site as small as possible. So getting decent apposition, although admittedly not ideal. So we can take a look at those tibial arteries giving down to 2-vessel runoff down to actually 2-vessel runoff, those reaching down to the foot and giving a nice blush in the foot on final angiography. So that particular patient went on to heal his wounds, this time with intervention on his 2-vessel runoff, opposed to allowing it to continue to progress with decreased flow in the foot. That blush in the actual foot, seeing those tiny microvessels come alive, is where I do believe that the below the knee portion of the IVL is going to be able to impact your practice. So case consideration number 2. And move over to an 81-year-old female who presented in my office with rest pain in her right leg. She's been confined to her wheelchair from the leg pain, unable to move around her house very well. She is a frail, multiple comorbidities, prior CABG, CKD. Not the picture of health, not someone that you're really eyeballing and going, oh, that's a good bypass candidate. Preoperatively, her arterial duplex, medial calcinosis through the tibial arteries, monophasic waveforms, but still there's flow in there. So for her, she was a left common femoral artery access. Again, that 6 by 90 sheath. You're going to notice a trend on me. I love to park that in the popliteal and highly recommend you try it out. 70% stenosis in her tibial peroneal trunk and an occlusion in the mid posterior tibial artery. Again, that 014 Glide Advantage. It's my favorite, that soft tip and the ability to work over it without having to exchange. And the 2.5 by 80 for primary therapy, right across, as you can kind of see, one of the lesions in the posterior tibial here before delivering impulses across. And then on the final, again, it's all about getting that blush back down into the foot and connecting. So taking a quick third case consideration, 75-year-old gentleman. These probably sound like just about every day in office for the folks on the call here. He does have a history of adenocarcinoma of the esophagus, chemoradiation, resection, coronary disease with a cabbage, presenting to the office with a new left heel wound, which he actually got as a pressure ulcer while he was recovering from his chemoradiation of the adenocarcinoma. Actually up a little bit better looking than you would expect in the office, starting to regain some strength. His ABI had some artificial elevations, with the medial calcinosis. You can tell by that TBI down there. And his arterial duplex, a very heavy calcium burden on the tibial arteries that are visible. So for this particular gentleman, right-sided, I was able to use a common femoral access on him. Again, that 6x90, parked in the left popliteal artery. He had a patent tibial perineal trunk, an occlusion of the posterior tibial with a long segment, and then reconstruction at the ankle from a branch of the perineal artery, as the intact plantar arch, and high-grade stenosis in the mid-peroneal artery. So occlusion of the anterior tibial that about 4 centimeters down occluded off. Again, that 014 Glide Advantage wire coming down from that long sheath, that 2.5 by 80 with impulses through the posterior tibial, then backing it up and driving it back down that peroneal. That good rewrap was what allowed me to really give him a much better result. Good signals distally in a healed up heel wound. So I'm just going to say thank you from rural Missouri, and thank you very much for the opportunity to share a few cases here and trying to give you an idea of healing wounds, combining technologies, and being able to really keep people in their communities and mobile.
Thank you so much, Dr. Roundtree. Amazing cases, and I'm sure we'll have a couple of questions about that towards the end of the webinar. We'll move on to our last panelist tonight, Chris Papsisky. He is a board-certified vascular surgeon with the Christ Hospital Heart and Vascular Institute in Cincinnati. He specializes in advanced arterial and venous disease therapy and has helped design the institution's multidisciplinary limb salvage and CLTI program. I know him from a lot of leadership and advocacy. He's active in physician leadership and advocacy and serves as the president of the Academy of Medicine of Cincinnati and vice chair of the Ohio delegation to the American Medical Association. His talk tonight will be From Theory to Practice, Javelin Case Experience in Challenging BTK Disease. Take it away, Chris.
Thanks, Nick, and thanks to the Midwest for the invitation and Shockwave for the sponsorship of this webinar. Good on the slides, Nick?
Yep, looks great.
Okay. So I wanted to pile on top of both Ravi and Caitlin's presentations and really focus on kind of the practical aspect of when you would use these devices. And specifically, we've been talking below the knee because this is the most challenging part of our job. I mean, these vessels are smaller diameter, smaller lumen. They tend to be more occlusive versus stenotic. They're long, diffuse. You've got multiple vessels you're trying to treat, and they're more commonly calcified, both superficial and deep, than above the knee. So treating these patients, you tend to get worse results with recoil, poor vessel expansion. We know this is our final frontier of limb revascularization, so to speak, because of the challenges that these patients bring us. So introducing the Shockwave Javelin IVL catheter on top of our balloon-based intravascular lithotripsy options. This is a catheter-based IVL device with a single emitter at the tip. This provides forward-facing or forward-approaching lithotripsy that goes out towards the front of the tip instead of through a balloon. This is designed to help you cross those calcific occlusions or really extremely narrowed vessels or even small caliber vessels um, in situations maybe where you're not sure an E8 could track, or maybe the vessel's too small to treat with a balloon-based IVL therapy. Here's the setup of the catheter. I want to point out that the emitter is towards the tip, not exactly at the tip. And then there's an IVL window where there's an inlet port and an outlet port that you flush saline through to cool down the emitter and also flush out those bubbles that we know that we get with lithotripsy. This is a 150 cm device. It's 5 centimeters L14, very hydrophilic, but stiff enough that you can really get some reasonable pushability with this. It's compatible with your existing generators, so no new capital equipment, and this gives you 120 pulses, 10 pulses per cycle. So when would you really use balloon-based or javelin? I think they're complementary depending on the patient and the lesion characteristics that you have. I don't think one is going to replace the other in your lab for sure. I think E8 is highly effective. It's proven, it's durable, it's been around a long time, and a long time in our practices at least. And I know it works. So where do I use Javelin? Javelin is for these really just challenging to cross lesions where maybe you just need improved vessel compliance to help you deliver additional therapy. And so here's an illustration, kind of just showing you the type of lesions that I usually think Javelin for. These are where you're trying to bury your balloon-based lithotripsy in the lesion and you just can't quite get the emitter to where you want to go. This is where Javelin excels. So as the Javelin slowly advances through that lesion, you're getting those cracks in both your superficial and deep calcium to really improve the compliance enough to be able to treat that vessel with definitive therapy. So let's review a case or three and really demonstrate the value of these options in detail. So case one is a 72-year-old smoker, ischemic ulcerations on the dorsum, those first three digits on his foot. Pre-op non-invasive arterial imaging shows primarily below the knee disease with a chronic occlusion of his anterior tibial artery. His distal posterior tibial artery is occluded at the ankle. His plantars seem to be reconstituted off of his peroneal artery and maybe a little reconstitution distally of his anterior tibial artery going into his DP on his foot. So my first approach is on the same thing as Caitlin. I love the steerable hydrophilic wires. Glide wire advantage is my go-to. It works all the time, most of the time. And I like to use a micro catheter to help get you down there. And then that catheter ideally can help you confirm that you're true lumen after you're distal to your CTO. And I IVUS 100% of the time. And I didn't start off practice IVUSing everything, but same as Caitlin actually mentioned, doing some of these clinical trials where you're required to do IVUS convinces you because you learn so much about what you don't know. And I think these vessel diameters surprise me. I've had tibial vessels that are almost 6 millimeters. I've had tibial vessels that have zero calcification, despite me being convinced X-ray that there is. And so I think it really gives you a reasonable and excellent picture at what your vessel diameter is, what your plaque morphology is, and allows you to really direct what choice of therapy you're going to select next. So for this lesion right at the ankle, circumferential calcium, basically 360 degrees right at the area of that occlusion, and only about a 2 millimeter vessel. For this patient, I chose a balloon-based therapy. And I chose a 2.5 by 80 millimeter E8. You can use this all the way into the ankle, distal tibial, as long as the size makes sense. 2.5 is the smallest E8 device. I think if you're oversizing 10%, it's very safe to use in a 2.0 millimeter vessel. Remember, this is a low pressure inflation. You're not doing a high pressure angioplasty balloon here. You're just doing 2 atmospheres there and letting the balloon mold to your vessel wall and letting it slowly expand as the vessel wall compliance relaxes. So as the pulses are delivered and the vessel wall expands, then I deflate and I move the balloon back to treat more proximally. So after IVL, I usually do follow up with angioplasty sized 1:1 with the thought in my mind of I'm just smoothing out that lesion to give a nice smooth caliber on the inside of the artery. And really excellent result. This patient healed within weeks, and I didn't have to come back to treat his anterior tibial like I was planning on doing. So, an example of where E8 really was successful, even in a small vessel. But what if you can't get your catheter to track through the blockage? You got your wire through. This lesion actually took me probably 45 minutes to get through. It was a real bear of a lesion to get through just because there's these boulders just kind of blocking the entire lumen. And I not only couldn't get my microcatheter through there to confirm I was true lumen, I couldn't get my IVUS either. So this picture is actually of the distal posterior tibial artery right proximal to that first large brick. And just, again, just obliterative annular calcification there. This is an ideal approach to treat with Chaplin. I think uh, when you're using Javelin, just approach your calcium with the tip. I have my tech holding onto the handle, pushing the button for me. I've got my finger at the sheath, putting just continuous forward pressure, and my other hand's pinching the wire. I'm not forcing this catheter forward. I'm kind of letting it jump forward slowly as the pulses do the work. So Um, please don't go this fast with your javelin. I don't know how this video sped up, but I couldn't fix it afterwards. But slow and steady is the key, and it really provides effective lithotripsy just with the catheter, not even using a balloon. And um, here is the vessel, even just after javelin, without ballooning or doing any type of further therapy. You've already created a really excellent lumen, really improved vessel compliance, and already starting to see some improvement in that hyperemia without even following up with a balloon, which I did. I also ballooned this patient's perineal artery as well. And here's our final result, just an excellent blush surrounding that ankle ulcer. Um, so this patient did go on to heal despite that EF of 25%. So third and final case, which was admittedly a doozy. This was a patient that was transferred to us with sepsis and right heel gangrene. Outside hospital arterial duplex imaging basically showed not a whole lot below the knee. Um, I never know if not visualized means it's occluded or they just couldn't find it, but I always presume it's occluded. Um, and just or severe calcium where you couldn't actually get an ultrasound image. But when I do my initial diagnostics, the ultrasound was spot on. Severe distal popliteal disease below the knee. Antertibial artery is gone shortly past its takeoff. The perineal and tibial perineal trunk are occluded proximally. Perineal artery seems to be the dominant runoff in the foot after it reconstitutes, and then going on to the mid calf, but then going on to the foot. Seems like distal anterior tibial artery is his main runoff, but where he needs the flow at the heel, not a whole lot right there. Caitlin was talked about access points, and I think if you can go antegrade femoral, especially doing multiple vessels below the knee, where you might need multiple wires, you might need extreme pushability to get some of your devices down there. I think antegrade femoral is optimal if your patient can. Um, I most commonly use up and over access, and I like to park the sheath just like mentioned earlier in the mid SFA or above knee pop. So I targeted the posterior tibial artery first, presuming this would be within the heel wound angiosome. And as I'm crossing these tibial occlusions, sometimes you just get stuck and I'll pull my wire out and do a little puff of contrast through the catheter. And I find that either tells you that it reassures that you're true lumen, shows that you're not in a dissection, your wire's not going out of collateral, and then also helps map the next few centimeters of your occlusion to track through. You can often find these little islands of reconstituted flow that you can point and aim your wire at next to help you kind of keep inching forward through these CTO crossings. But I made it down to the ankle, but I just could not get my wire into that plantar artery at the bottom of the image there. So I parked my wire tip at the ankle and I IVUSed. But again, I couldn't get the IVUS past the mid calf, and I was surprised because on X-ray it doesn't look that calcified, but obviously this occlusion's been going on for some time, and the IVUS confirmed that at least in the proximal half of that occlusion, severe circumferential calcium. This is a more representative speed on your javelin, just slow and steady, 1 millimeter per second. Just kind of let the pulses do the work, and you'll almost feel the pressure ease up on that catheter as it slowly just kind of drives forward. So after javelin, I ballooned the posterior tibial artery, and here's kind of what I was left with. Man, not bad, not great. We're certainly not done. Um, this is not going to be good enough for him to heal, but we're moving forward. So I left my wire in the posterior tibial artery and tackled the anterior tibial CTO, and whoop, we all kind of start smiling. There's a pedal arch, and your options improve so much more when you've got a pedal arch, and you can really tackle some of those challenging distal tibial occlusions around the horn like this when you've got a pedal arch. So we were able to successfully use a buddy wire and kind of have both wire tips kiss there in the distal posterior tibial artery. So IVUS, the anterior tibial artery, was able to IVUS all the way down, and diameters ranged from around 2 millimeters at the ankle up to about 3.5 millimeters towards the ostium. So a pretty variable tapering diameters there. And I'm not one that I'm going to open 3 different IVL devices. So I try to pick one that's sort of makes the most sense. And I think even in a 2.1 millimeter vessel, a 3 millimeter IVL at 2 atmospheres is still safe. And you can still get effective compliance improvement. And then, I'll use closer to 4 atmospheres towards the proximal part of that. Following IVL, I ballooned the whole vessel to really maximize the luminal gain that I could. And here's our pictures after treatment of the anterior tibial artery. Still kind of sluggish flow through that posterior tibial artery. So I ended up pulling my anterior tibial wire and going back down the posterior tibial, where I now was able to steer it into the lateral plantar artery, and did a run through my catheter right there at the mid calcaneus, and yep, shows that there's still a lesion within the lateral plantar there that I re-ballooned. So after treating the proximal fempop disease, there was a TP trunk dissection there. I put a scaffold in, and here's kind of where I was at after 3-ish or more hours of working. This is where everybody in the room starts reminding you it's perfusion, not perfection, and you stop. But I stewed on this patient for a day or two, wondering there's such a significant improvement for him, but is this enough? And that posterior tibial flow where he needs the perfusion still a little sluggish. So have a low threshold to re-intervene. I've kind of learned this the hard way. If you're not super vigilant with these patients, they're going to find a way to undo all the work you've done. And so I brought this patient back a couple weeks later, and yes, the distal posterior tibial artery was in fact reoccluded, probably at that same spot in the lateral plantar. Even though the whole foot lights up so much better, the heel still has absence of that blush we want to see. So was able to get through this easily. I was able to get a wire around the pedal arch through the posterior tibial into the distal anterior tibial artery, and I IVUSed that lateral plantar this time, and just saw a really sharp focal shelf of dense calcium there. And it actually, when I IVUS, you can feel my tip of my IVUS catch on it, and it would jump forward. So I knew that was a significant chunk of calcium in a very small vessel, less than 2 millimeters. So I javelin this one. I think below the ankle is really where the javelin hits its optimal treatment strategy. I think not only helping you cross calcific occlusions, but just treating small vessels. Uh, Maybe not going to use a balloon in the foot with a tiny vessel like that. I still probably would, but I think Javelin really excels here. And so I spread all 120 pulses right from the mid calcaneus into the pedal arch. And I think I ended up getting 3 or 4 passes in through there. And immediately after Javelin, just by itself, excellent luminal gain, significant improvement of that hyperemus starting towards the ankle, and I ended up angioplasting this afterwards. And here's just as a reminder, kind of what we started with when that patient was initially transferred. Here's how it looked after the first stage, and after I decided to bring him back, here's kind of how we finished. Um, and so this is a result I can go home and sleep over and know that, hey, I made a difference. So with that, I'll stop and turn it back over for any questions, and thank everyone for listening and the invitation. I appreciate it.
Thank you, Chris. Wow, marvelous, marvelous cases, and it probably took you a long time to do that. So, but obviously, of course, it's amazing with fabulous result. I actually, it's open up for any questions. If anyone has any questions, please get into the chat. I know we got a few more minutes. We do have one, and I'll put this out to the panel. The question is, what is the fate and history of the treated vessels? Does the calcification come back with a reckoning, like a lead pipe, or does the sediment become granular enough for reabsorption and degradation? So when you're redoing it, for those that you've redone, what are you really seeing? And maybe we'll start with, how about we start with you, Robbie, first?
Yeah, I think for the people that I have had to re-intervene on, which has been a couple now, I think what Chris said is very accurate. I think when you're trying to heal a wound and you've been working for a while, sometimes you can kind of get tunnel visioned a little bit. Taking a step back, sometimes listening to your trainee, it's like, come on, man. And being happy for that moment and bringing him back. I think it is easier to cross those lesions. I found after IVL, I think my wire flies down a lot better, which then lets me treat more effectively, I think, because now you have all that time you spend on that hard cross is gone. And now you can kind of think, do you want to take a javelin out and smooth that area over? What could you have done different from that first time that you intervened on you learned? I feel like it's a little easier to kind of treat those the second time around. The calcium effect of the IVL has already occurred, so it's a little easier, I think, the second time.
Great. Caitlin, anybody else want to comment any more on that? Or
No, I think that was well handled.
okay,
I'd agree
perfect.
with a little bit of that tunnel vision aspect. It
Yeah.
probably gets all of us.
I
Fine.
think some of the assumption of that question was that, is some of that calcium moving after IVL? Are you embolizing? I think this is one of the reasons why IVL is taken over atherectomy. I think a lot, especially below the knee, is it before, when our only option was an aggressive atherectomy. Yeah, you couldn't control where that calcium was going to go. That, how are those particles getting resorbed and what was going to happen? But sometimes you were stuck. You didn't have a choice. It was either not treat the patient or take a risk. And that was a risk of to the patient and the risk of us not making it home for dinner. But with IVL, it's been so safe. I don't think I've ever even seen, I can't say never, but you rarely see emboli from this. So you really are just softening the calcium so that it can be compressed a little more aggressively than you otherwise would. And 100% agree with Robbie. When these patients do need to come back because they're not healing or they recur, so much easier to treat the second time around. So you're able just to kind of pile on and still move forward with the treatment that you did before.
Yeah, I
But
think someone just asked that question in the chat about embolization, and I agree completely. I haven't seen it yet. I think the one thing that for the people that are especially starting out and starting to get into kind of this complex PAD world, IVIS, my opinion, I mean, always IVIS, but also IVIS after IVL. If you're even if you're going to use another definitive balloon, so that you can see what you're doing to the vessel. I think that tells you a lot because you can see that calcium that you see on the initial IVIS run look different and kind of push down a little bit. And that may give you a visual representation of why it is different than other devices and may lead to that reduction in the distal embolization.
do have any of you just on before we move on to a different topic on the concept of distal embolization? Do you guys do javelin? Have you ever done it over a filter wire? Do you think it's necessary to do it over a filter wire?
I'm a huge fan of filter wires, but I've never used one on a javelin. Um, really, any of the thrombectomy, atherectomy devices, rotational screws, you name it, I was using a filter wire and pulling stuff out of that filter basket. On the javelin, really where I've seen it shine is in those tiny little vessels that you otherwise would never have touched in the first place. I don't really want to put a filter wire into the plantar arch. And with this one, I don't feel like I need to. I've been using IVL really honestly since the last little bit of my fellowship, and then I'm an early career physician, I'll admit it, but throughout my entire career, um, I've been extremely fortunate to not have had an embolization event. One dissection from a horrible crossing that I probably was in a false plane anyway. But no, I would not use a filter wire or actually feel the need to with the javelin.
Oh,
Well,
now
we
you've done
talk.
it.
Sorry,
I
go ahead.
know I've got no
Now you've
wood to
done
knock on.
I don't know. I
I'm
was just
on
gonna
call
say,
this weekend
well,
and I'm
it's
hosed.
coming. Uh,
It'll be
um,
a long.
Mhm.
Uh,
Yeah.
I know we spoke a lot, and the concept is, the case for IVL first therapy. So, how many of you are using this first? How many of you are using this only? Is it destination there? Is this the destination, or is this basically vessel prep, or this is adjunctive to what your ultimate treatment is going to be? I'd be interested to hear.
I think for me, it's vessel prep. I think, if you're creating these micro cracks in your calcium, even with balloon-based IVL, I want to smooth that out with one long balloon. Because I don't get to see the lesions often where these short little focal areas where you could do standalone therapy. You're using that E8, 3, 4 times. And so putting in a long 200, 240 cm balloon to smooth that out, that is my destination therapy. I think uh, javelin specifically is just vessel prep for the next step.
Yeah, I would have to piggyback that. I think vessel prep for sure. I also use kind of long tibial balloons to treat it to kind of disperse that atmospheric pressure over the whole balloon length. I think that decreases your tibial dissection rate. And then for honestly, knee and above, I will still use drug for most of my definitive therapy.
I'm kind of a mix between you fellas that really popliteal, even a good size to go parental trunk. I'm using a drug coated balloon as a follow up through, but the IVL is letting me use a 200 millimeter instead of a 60 or a 40 or a more focal high pressure aspect there. As I get down into the tibials, I'm more limited in what's on our supply shelf in a rural hospital. So I am using those E8s as my definitive tibial therapy. And honestly, the javelin in the foot is I have a hard time wrapping my head around putting an 80 around that ankle. So I've got a couple of people I've taken the javelin up and around their plantar arches and left it at that. So
Well, since there's a lot of interest with IVUS and sizing appropriately, so how are you guys sizing based on IVUS? I mean, you guys are going all the way to the outer, to the adventitia, to the outer side of the wall, or to the media, or how are you guys actually sizing it based on IVUS? Maybe for the audience.
If it's 360-degree calcium, I'm sizing to the calcium, expecting that's probably where we need to start. If it's less than 270, 240, I'm sizing to that black rim you can see around. It's a lot easier to see that above the knee than below the knee. But I am more aggressive sizing to the true diameter of a tibial than maybe accepting I'm only going to get so much above the knee. I'm treating 1-to-1 with, at minimum, with below the knee.
Yeah, very similar. I think that tibials, at least 1-to-1. I agree with the statement that Chris made in his presentation. Even if 2.1 millimeter tibial can take a 3 millimeter balloon at 2 atmospheres. I think that is that's the beauty of this low pressure inflation balloon. Um, Decrease that vessel trauma. But I think in the patients that in my earlier experience that I was undersizing, I didn't like the 1 month outcomes, 6 month outcomes. And now that I've gone more to that 1 to 1.1 sizing, I think my patency has been great. And I think less than reintervention rate, which I think is everything.
Touching on the javelin, one more quick time. Are any of you using it? And I don't see without the wire, but are you always having to cross the lesion before using the javelin? Or are you able to basically have the wire stick out just the tip and then kind of use it as a forward energy device or forward emitting? Or do you have to actually cross and then have the energy help you, create a bigger channel?
I've
I've
used
done
it.
both. Yeah, go
Um,
for it.
I'm sorry. I've exclusively used it with wires across. I was at Mizzou and we were part of the Ocelot trial as far as kind of, I don't remember the exact name of that, but you had to be like half drunk to be able to interpret that thing. That was an interesting imaging.
OCT.
So there we go. Thank you.
Yeah.
A fellowship with, a sidewall. But no, I've had the wire across, and it's those where either you knew that wire was real hard to get across, you're looking at areas that were occluded, or I try to get the balloon down in the first place and go, I'm going to destroy this balloon if I keep pushing on it. I'll get the javelin cross there, utilize the impulses, and then come back with the E8 if I'm outside the foot.
Obviously, IFU is wire across the lesion first. Um, but I think that the design of the catheter is a really good balance of flexibility and pushability. And I think having that wire through allows you to really optimize success. And I prefer, after I use the glide wire advantage, I'll switch out to a stiffer workhorse wire just to take advantage of that.
All right, just to round this out, Dr. Roundtree, real quick, there was a question from the audience. In that case, that patient of yours that they had a dissection, do you feel that was because of wire technique, or do you think it was related to the device itself?
Oh no, that was absolutely surgeon related, not device related. That was crossing a completely occluded superficial femoral artery with whatever plane I could get, getting true lumen again. There was so much calcium on that radiograph as I was working that really I put in. I want to say it was an 8 by 60 that I had on the shelf to be able to use IVL and then putting stents across it. Uh, I'm going to go off topic for a hot second. Just that makes me think, why did I use a lithotripsy balloon opposed to just a covered stent with the risk of perforating the vessel? I'm going to jinx myself to kingdom come on this one, but um, it's coming, and you know what I'm going to say. When I was a fellow, we put in a lot of in situ bypasses, if you will, covered stents through the SFA, above knee, and then you're running TPA, and you get really good at running TPA because there's some lesion in there that has the entire thing squished. I'm knocking on everything around me because it's going to happen, but I haven't had to run TPA since I've started using IVL. Never mind consistently like we were. Um, is allows you to actually get those stents in appropriately sized, truly open, and decrease your stent failure down the road. Decrease your having to come back, TPA it, fail it, bypass it. Um, so that was
And
definitely a
IVL
surgeon
is
related.
IVL is I've had really good success in the subintimal plane. And I
Oh,
know
it's
you're going to be a
fantastic.
lot more hesitant to try any of the atherectomy types subintimally. I think you can feel pretty comfortable using a low pressure device to help your stents optimally expand.
Great. Well, look, I
Yeah,
know we're at the top of the hour. Just one more quick. I'm going to put a comment here. There's a comment about carotids. Work is in progress. There are a dedicated device and a trial that IDE trial that is starting or has started. So more to come on that. But look, we're at the top of the hour. I want to thank very much our panelists for joining us today. I want to thank the Midwest Vascular Society, and we want to thank Shockwave for sponsoring this, and of course, our audience for spending their evening with us tonight. So feel free to reach out. We really appreciate your attendance, and we will see you next time. Okay, everyone, have a great evening. Thank you all.
Thank you.
Take care.
You guys.